start with maybe some individual introductions. Just say who you are, what's your specialty, how long have you been in the field, and what sort of drives you to keep doing more for NMOSD and MOGAD. We'll start with you.
Thanks. So I'm Jackie Nicholas, and I'm a neuroimmunologist in Columbus, Ohio, and I've been doing this since 2011. I actually decided to become a neuroimmunologist because of the first patient that I diagnosed with NMO. And I remember being so shocked by the lack of awareness of this disease. So it's really awesome to be here today and to see what this organization has done.
Thank you. My name is Amy Kunchok, and I've been involved with NMOSD since 2010. And I was also inspired by a patient back in Australia, and you can probably hear that I'm not a local. So I also had a patient that was had very severe NMO, and I looked after her in the hospital for many hospital missions for plasma exchange for visual impairment. And I think at that time my interest really spawned for neuroimmunology, and that actually led for me to come to the United States. Actually, that was the reason I came, was to do neuroimmunology, and I went to Mayo to learn more about it, which is the reason I'm here, and made it to Cleveland. So I am very fortunate to work with the wonderful team at Cleveland Clinic, and some of my colleagues are here, and I'm so happy to see some of my patients here and to see all of you. Looking forward to the day. Thank you.
Hello, all. I'm Mary Rensel. I've been in this I'm a neuroimmunologist for almost 30 years, but who's counting? But I love the fact that I get to know people through their whole lifetime. When we train as neurologists, we kind of pick what kind of neurology we might want to go into, and some of the options, we meet people at their end of, towards the end of their lives, like in their 70s or 80s. And I appreciated with neuroimmunology, I got to meet people earlier, because even some people in this room I've known since they're 11. And that person, Mayo, called me because of their blood test, because it was so high. When Mayo calls you as a physician, something's up. And that opened the door to us wanting to know more about NMOSD, partnering with Mayo Clinic, and realizing we need more options, and just trying to support the people through their life cycle. So I'm honored to know people. I have somebody who keeps showing pictures of her child, or her little boy, who's so cute, and I've known her since she was 9. So I'm really honored to know people through their life cycle, and to see them thrive. That's my honor. Yeah.
Thank you. My name is Hesham Abboud. I'm a neuroimmunologist at University Hospitals, Cleveland Medical Center. I've been in neuroimmunology since maybe 2005, but officially a neuroimmunologist since 2015. Got really interested in NMO in particular after seeing a patient with tonic spasms. You guys know what that is? I'm sure some of you do. I was very fascinated by how the spinal cord can generate movement disorders, and I've been studying this since, and trying to help patients as much as possible. And I got into NMO clinical trials because of Dr. Rensel during my training, and still in it since.
Hello, Justin Abbatemarco. I also work at the Cleveland Clinic. I've been doing this since 2015 in the field of neurology. And I love the comments about patients. I couldn't agree more, right? Some familiar faces in the audience, which is incredible. Maybe another angle to this is like NMOSD and MOGAD, I think, included, right? How rapidly this field has moved is maybe even give hope to some other patients that we see in our field, and to just see how we've gone from bench to bedside with these new therapies has just been incredible. And so to be a small part of this conference, yeah, it's an awesome opportunity.
Thank you. What a treat for me to be moderating a panel with such experts. So let's start with the basics. I'm going to call on each of you, I'll call on you for a question. So my first question is, we'll start with Dr. Abboud, my brother. Can you share what the 2024 definition of NMOSD is and common symptoms?
So we use currently the 2015 criteria, which is being updated, but according to the criteria, if you developed optic neuritis, which is inflammation of the visual nerve, or transverse myelitis, which is inflammation of the spinal cord, or specific parts of the brain, and you're positive for the antibody against aquaporin 4, then you have NMOSD with aquaporin 4. If you don't have the antibody, then it's a little bit harder. So you have to have at least 2 of these areas inflamed, and then there are specific features on the MRI that you have to also fulfill that basically distinguish NMO from MS in terms of how long the lesion is in the visual nerve or in the spinal cord and so forth. So I think this is what we go with currently. The symptoms depends on where the location of the lesion is. If it is in the visual pathway, obviously loss of vision, typically painful, one or both eyes. If it's in the spinal cord, paralysis, loss of control over the bladder and bowel movement, and tonic spasms or involuntary movements is another common symptom. The brain has a variety of symptoms. One of the most famous is intractable vomiting and hiccups.
Thank you. Dr. Nicholas, can you share the most current definition of MOGAD and common symptoms?
Sure. So with MOGAD, these are individuals who experience, they can experience inflammation of the optic nerve or optic neuritis, and they also can experience transverse myelitis. And that means basically inflammation of the spinal cord. So many of these symptoms are actually very similar to the symptoms that Dr. Abboud described for NMO. With these symptoms, patients would also need to be positive for the MOG antibody, the myelin oligodendrocyte glycoprotein, and that's a test that we typically do in the blood. It can be done in the spinal fluid, but these individuals often experience recurrent episodes of optic neuritis or transverse myelitis, and so typically have visual impairment, problems with bowel and bladder, can be weakness, neuropathic pain, you name it.
Thank you. Dr. Kunchok, I've seen and read so many numbers all over the place, but I want to hear it from you. What is the current prevalence of these both diseases in the US, but also worldwide, if you have that info?
I'm not sure if I have the info at the tip of my tongue. The NMOSD epidemiology that I've looked at has been varied, and the rates that I've seen have been between sort of 1 to 10 in 100,000. But what I've seen is the rates are quite varied because of the different geographical distribution, and there may be different methods also the way when studies are done about why there might be different numbers, but it's generally quite rare. We tend to see it more clustered in people that live closer to the equator, which is of interest. I don't know if we fully understand why that is. Is it something about the environment, or is it something about ethnicity? But that's there is a bit of a gradient, and that's sort of the opposite to what we might see for MS. For MOGAD, it's more frequent than what we see for NMOSD. So in adults, we probably see about 3 to 1 ratio of how frequently we detect MOG antibodies. And in children, MOG is much more frequent than NMO. So NMO is something that more often affects adult women, whereas MOG often affects younger children and younger adults. So they have a slightly different demographic, and we more frequently see MOG overall than NMO. The main difference probably is that we also have a shorter time frame of knowing about MOG. So although it's probably more frequently encountered, it's only been a test that's been available since 2017, and so we have only just recently started recognising that patients have this disorder. And whereas NMO we've known about probably dating back at least 20 years now, and we've had testing for it since about 2004 or 5 available.
Yeah, that's actually the perfect segue to my next question. Dr. Rensel, I think this is more related to MOGAD, but can you explain the difference between monophasic versus multiphasic aspects of these diseases?
Sure. So it's challenging. So when somebody comes to us, so the terms mean monophasic is one spell of symptoms. So one time having some new neurologic symptoms, whether that be visual symptoms or numbness or weakness, maybe like the hiccuping, the throwing up, the persistent throwing up. So that can happen once, and we will call that monophasic. And then sometimes only time will tell us if it's coming back, and so that could be multiphasic. So sometimes we see people their first time, and they said is this coming back? Or am I good? And sometimes we can use the blood test to know the risk level of having another event, having a second event or a third event or a fourth event of different symptoms or similar symptoms.
Thank you. Justin, I saved a good question for you.
I'm ready.
Okay. Over the years, I've read a lot of different conversations online about between patients and caregivers about a myth that I would like to debunk today. Can you have MS and NMOSD or MOGAD?
I think it's such a good question. I think we even talk about it with our trainees, and I think patients experience this, right? Because I think sometimes when we're in the clinic, we mention all of those words. Sometimes people will say MS or MS cousin diseases when we're discussing some of these rare diseases. I think the simple answer is no, you cannot have, again, multiple diagnoses, but it can be really confusing in the clinic. And I think we simplify it up here, right? When we first see a patient and the testing's not back, we're kind of keeping that broad list of possibilities. And once the testing comes back, time can sometimes be the other piece to the puzzle to help figure things out. But we can usually identify one of those kind of diagnoses for patients. I know that we've all experienced this, though. There are patients that do not fit into one of those buckets. And sometimes we're between them, and I think we'll talk about some future avenues of research that we're going to have to help some of those patients. And we'll use maybe medications that we think work a little bit more broadly. But I think the simple answer is you cannot have you can usually fit into one of those buckets. We'll think about all of these diseases. Again, we've heard that these symptoms overlap. And then sometimes when we're a little bit confused which happens, there are medications we can use to help those patients. Does that help?
Helps. Yeah, I think so. All right, Dr. Abboud, can you break down, or simplify rather, aquaporin 4 antibody for NMOSD, the MOGAD antibody for MOGAD, and then seronegative NMO, or double seronegative?
Excellent. So the first antibody is the anti-aquaporin 4 water channel antibody. Aquaporin 4 is basically simply a water channel on the surface of specific cells in the central nervous system. We call them the astrocytes. And this is the primary target of the antibody in patients who are seropositive. When this happens, this will result in the symptoms that we just discussed, because the water channels are very rich in the brain, the spinal cord, the visual pathways. And then the nearby cells, including the nerve cells themselves, will also get injured, typically presenting those symptoms. MOG antibody is directed against the specific protein on the myelin, which is the covering of the nerve cell, that is produced by a different cell called oligodendrocyte, hence the name. And this is a purely demyelinating disease. So when the antibody attacks the myelin, it strips off the nerve cell from the myelin, producing the symptoms that we just discussed. So of all three, MS, MOGAD, and NMO, MOGAD is the true, purely demyelinating disease, and that's why it recovers very well, because the myelin can be repaired, typically. Now, double seronegative NMOSD is when you have a clinical picture similar to NMOSD, not typical of MS, but when you test the two commercially available antibodies, you're negative for both. Is it caused by a different antibody that we don't know how to test for? It's very possible. That's why we're trying to see if we can test for new antibodies. Is it a disease that is not produced by an antibody at all? Sometimes it's mediated by what we call T cells. That's also a possibility. It's harder to test for that. But what we know is the clinical picture should be different from MS and closer to NMO and MOGAD. Before we were able to test for MOG antibody, we thought that MOGAD was seronegative NMO at the time. And then if you test people with seronegative NMO for MOG antibody, about 50% of them will test positive for MOG.
Thank
So
you.
it's an evolving field.
Yeah. Just out of curiosity, raise your hand if you test negative for both antibodies. Okay. Interesting. Yeah, we have a Facebook group too if you want to join it. But there's a lot more of us than I think we originally thought. So we can be in no man's land together. All right. Dr. Nicholas, in a perfect world, can you sort of describe the pathway to a diagnosis? So someone comes in with symptoms in the emergency room. What tests would they need? What imaging would they need? And so on and so forth.
Yeah, absolutely. So in a perfect world, I think somebody would come into the ER and the physician seeing them would listen to their symptoms, consult neurology. A neurologist would likely come in and do an exam and identify where their problem was coming from. I think most commonly somebody would come in with one of these diseases being either optic neuritis, visual symptoms, or spinal cord symptoms. Although, as mentioned, it can be really tricky if somebody comes in with intractable nausea. That oftentimes leads to quite a delay. But they would come in, examine them, and maybe have some findings on their neurological exam that help them to localize where the problem is. Maybe it's the optic nerve, or maybe it's the spinal cord, or both. And then they would typically end up getting MRIs. MRI of the brain and orbits to look closely at the optic nerves, to look for signs of inflammation and maybe other lesions within the brain. Lesion is just a fancy word that means an abnormality or a spot. And sometimes where those spots are can help to determine if this is something like multiple sclerosis or something that we might see more in MOGAD or NMOSD. And then spinal cord imaging as well. The spinal cord, if we're looking for lesions, we might see longer spinal cord lesions in the setting of NMOSD. The classic teaching is 3 or more vertebral bodies in length, so very long lesions, as opposed to multiple sclerosis, where we see tiny patchy lesions. We can see longer lesions in MOGAD as well. It really depends. And then also the location of the lesions. So sometimes in MOGAD, we may see more conus type lesions, or lesions really at the base of the spinal cord. And then there may be spinal fluid testing that is done as well to look for signs of inflammation or other conditions that might look similar to these diseases, to rule out these conditions. But I think of very high importance is early on the clinician being really suspicious for one of these conditions and sending the blood test for MOG IgG and the NMO IgG, or the aquaporin 4 test. Because sometimes if somebody's treated or they're given steroids early or plasmapheresis, that might actually take away our ability to detect the antibody. So those are really important tests initially.
Thank you. So just a bit of a backstory. When I was diagnosed 10 years ago in Boston at Mass General Hospital, one of next to Cleveland Clinic, or after one of the best institutions in the world, I left my hospital visit upon discharge with a few sort of takeaways. The prognosis was not good. There were no approved therapies. Everyone said, do not Google NMO. Of course I did. And yeah, I mean, everything that we saw on the internet at the time, and unfortunately this information still exists online, said that patients would be, would pass within 5 years of their diagnosis. So obviously, getting diagnosed with this is not the most pleasant of news. But fast forward now to 2024, we have 4 FDA-approved therapies that seem to be working quite well. And this has kind of changed the landscape of NMOSD because, and actually I would say rare disease, because less than 5% of rare diseases have a therapy. So the fact that we have this luxury of choosing a treatment that is designed for us really, really is a game changer. And then, of course, the MOGAD antibody was made commercially available in 2017. So now patients are able to get accurately diagnosed, hopefully for the most part, even though I know it's still a challenge. So all this to say that we have really come a long way just in the last 5 years alone. And I just want to say thank you again to our therapy partners. I know that for many of you, it's a job, right? It's a means to an end. Of course, you feel passionate about it, but everything that everyone brings to the table, including the clinicians and the researchers and the advocates, has resulted to where we are today, which is really, really a unique position to be in for a rare disease. So thank you, everyone, for all of the work that you're doing to advance these diseases. So on the topic of treatment, Dr. Kunchok, can you explain and kind of break down acute treatments versus preventative treatments?
So when a patient first presents with acute inflammation, we use very general treatments that settle the inflammation down and hopefully improve whatever disability they've encountered. So that might be vision loss, it might be difficulty walking. And so the typical treatments that we would give would be steroids, and that's often given in the hospital, but sometimes it can be given in the outpatient setting. And often it's given via a drip for 3 to 5 days. And sometimes people are given some tablets of prednisone or steroids afterwards to take for several weeks. So that's often the first treatment that people reach to. And steroids are a very general type of treatment that can be used for many types of inflammation and autoimmune disorders. If patients have a lot of severe impairment or disability, sometimes they have additional treatments that are given to them. And they can include plasma exchange, which I mentioned earlier. And that's a treatment where the blood it's like being cleaned, a little bit like dialysis if you've encountered patients that receive dialysis. And a patient's connected to a machine which basically cleans the blood. And this can go for about 2 weeks. And then another treatment that's sometimes given in the acute setting is called IVIG, and that's a treatment that comes from the blood bank. So it's from patients who have donated blood, and then the blood is filtered into different categories, and one type of treatment that comes from the blood bank is called IVIG. And it's actually immune cells from other patients, and it works also in settling down inflammation. So those treatments often occur in the first couple of weeks when a patient experiences an attack, and not all patients will get the same treatment. It depends sometimes on what's needed in terms of their severity, and also sometimes some other medical factors that need to be considered. So after the acute treatment, because we're concerned about patients having a relapse, we then think about trying to prevent a relapse. And so we consider it's often quite a considered conversation, and we think about what treatment might be suitable for that patient to take longer term. And that's because we don't want patients to continue to have attacks. We also don't want to rely heavily on medications such as steroids that can give a lot of side effects. So the treatments that we have available are different somewhat between NMO and MOG, but they also have some overlaps. And I should say for MOG, there's not as much research that's been done because it's a fairly new disorder. So how MOG is being treated is evolving quite a bit, and will probably continue to evolve. So I'll just mention briefly, I'll start with NMO. We have some treatments that are approved by the FDA, and these are treatments that you may have heard of, and I know we have some representatives from some of these therapies today. We do, just to mention them briefly, we have a treatment called satralizumab or Enspring. We have a treatment called anebulizumab. We have a treatment called eculizumab. They're all basically treatments that either are infused or they're given under the skin. And those treatments people continue on often for life for NMO. And that's another whole topic really about duration, but these are long-term treatments. Before we had these 3 new treatments available, a lot of patients were treated with rituximab, so you may have heard of that treatment. That type of treatment has been used for autoimmune disorders of many types, and is again an infusion that's given every 6 months. And some people may have also, particularly if you were diagnosed earlier, been treated with other types of treatments such as tablets like azathioprine or Imuran or mycophenolate, also called Cellcet. So we have there's a range of treatments that are given for NMO. For MOGAD, the initial treatment is very similar. Long-term treatment is still an area that's really being investigated a lot more about what's the best treatment for MOGAD. And I think that this space will be changing over the next couple of years as we understand more about MOGAD patients. But just to mention a few types of treatments, we sometimes use steroids, tablets, but they do have side effects. We use IVIG, which I mentioned is an acute treatment, but also can be given long term. And then there are some trials that are investigating satralizumab, which is used in NMO, and there's another treatment called rozanolixizumab, which is a tongue twister. So there's a few treatments that are being investigated in trials, so we will probably understand better their role and how effective they are in the next couple of years. So happy to, there's kind of a lot to take in about all the different treatments, and I'm happy to, later there might be opportunities to talk more about these in detail.
That was a great summary. Dr. Rensel, I know how passionate you are about health and wellness and holistic health and all of that. So in a perfect world, how do you envision a multidisciplinary care team for NMOSD and MOGAD patients? What specialists would be involved?
Yeah, we've been fortunate at the Mellon Center. So there was a family, the Mellons, and not the melon like the fruit. Okay, it's E-N, melon. Everyone's like, that's so cool. It's called the Mellon Center, just for your melon. And I was like, no, it's E-N. So as a family, and their desire, their dream in a perfect world, they wanted, because Mrs. Mellon had MS, and they wanted one center with people who could help her with her MS and other people living with multiple sclerosis. And so the Mellon Center has always had that that basic philosophy, is that we are a team. So we've always had nursing, physical therapy, occupational therapy, neuropsychology, behavioral medicine, just social work, on, and clinical trials, as well as clinical care, day-to-day care of people living with these diseases, as well as clinical trials, because we wanted to have an impact on the future for those living with these diseases. So we want to make sure we always talk about having a team. It takes a village, literally, to care for folks and to enhance wellness. And we like to talk about wellness right away from the beginning of the diagnosis, because there's a term called brain reserve, which means kind of like your saving account. How can you keep your brain healthy when there's another autoimmune disease there as well? I always like to say the brain is more of a garden, less of a brick. So we can influence it. There's things that we can do day to day. We'll see what lunch has. Well, I'm going to check your plates today. See what nutrition matters, right? So we'll see what lunch, and just connection really matters. So you can check a box today. This really helps us, excuse me, in a neuroscience way to feel comforted, to feel supported. So thank you, Samara, and your team. Because that really matters for us as humans. We need a team. So we've always done that at Mellon.
Love that. And I just want to also say, mental health is such a big part of our journey, whether, it's just mentally affected by having the disease itself, but sometimes our therapies can cause all kinds of unpleasant side effects. So, if you don't have a mental health professional in your care and that's something you want, it's perfectly normal, it's perfectly within reason, and you absolutely should. I need to take my own advice. That's actually on my to-do list, to get a therapist. But, life is hard, and life is even harder with a rare disease that's very complex. So if you feel like you need a mental health professional in your care team to help you navigate this journey with a rare disease, just hear it from all of us, perfectly normal. So don't let any of the stigmas of mental health keep you from getting the help that you need and deserve. My last question, Dr. Abbatemarco, it's about the R word, relapse. Also, recrudescence is another R word I learned recently. So can you share with the audience, the live audience and the virtual audience, what is the difference between a relapse and a pseudo-relapse?
No, it's such an important point, and it's really confusing. So relapses, when we're talking about it maybe in our setting, we're thinking of new inflammation that, the medications are not working, that are producing these totally new symptoms. And again, that's a big kind of point for us, because we have to think about different medications to make sure we get rid of that. Recrudescence, pseudo-relapses, there's so many different terms out there. We describe that usually as this kind of reemergence of old symptoms, right? All of these therapies that Dr. Kunchok mentioned, none of them repair. They only prevent and help recovery. So sometimes those old spots that remain on the brain, the spinal cord, the eye, those symptoms will kind of reemerge in times of stress. And I tell my patients, I mean that in the broadest way possible. Mental or physical stress, infections, sometimes the summer, the heat intolerance is really tough. So that relapse, usually meaning new inflammation, we've really got to rethink about our kind of treatment paradigm and how we're approaching that. that pseudo-relapses mean those old spots, those old lesions, those old scars kind of re-emerging their ugly head. And there we have to think a little bit differently about how we rehab and recover. And again, this multidisciplinary team that Dr. Rensel mentioned, both mental and physical wellness are so important there. Needed just in time.
Perfect. Actually, I do have one more question. It's a selfish question, but you know, you've all been in this field for a long time, and you've witnessed and observed the evolution of these diseases. You've seen it at its worst, and now you're seeing it today, you know, June 15, 2024, these diseases are at its best. Of course, there's a lot more work to do. Of course, there's a lot more to learn, but we have come so far, and I'm sure it must be very rewarding for all of you up here to see sort of the fruits of your labor, you know, your contributions to research, or the community's contributions to research, and seeing all of these scientific advancements. I'm sure it's very, very rewarding and exciting. But now that we are where we are, I'd love to hear from each of you. What excites you about being in the field now? Like, what's next? What are you excited about?
Yeah, so I think what excites me about this field, particularly these two diseases we're focusing on today, is that we actually know the underlying pathology of them. Despite the disease that, you know, we've known about for a very long time, multiple sclerosis, we still have more questions about the underlying pathology than we do with NMO and MOGAD. So I truly believe that we will be able to find a cure for these diseases in our lifetime, and I'm pumped for that.
Me too. Dr. Kunchok?
Thanks. What a great question. There are so many. There's been so many great advancements and understanding of these disorders from science, and mostly from patients that have contributed to science, and that's really helped move the field along. I think I'm really interested in but two things: prevention and cure. I think prevention is an area that would be wonderful if we could identify patients that are potentially at risk in the future, to prevent these diseases from even starting, and then for people that have the diseases to be able to find what mechanisms that we can actually repair, not only repair, but actually cure and halt the disease, so people aren't left with being on medications for their life. That would be optimal.
I would say I would love more precision. So I think that's coming so that we can know, we can almost have like a immune signature when we meet you. It's like, well, we see this and that and this, and here's your almost like a recipe for your immune findings. You know, we know that now with when we see that blood test for NMO that we now have these treatment options, but could there be more precision? Because the treatments aren't perfect for everybody. And so I want more. I want more. I want, you know, perfection. I want no risk of relapses. I'm so glad because I've been in this field long enough that we always knew something was different about NMOSD and now known MOGAD patients, that, you know, when the parents would ask me, is there a risk for death? And there was, and there was. And we had to say that. And they were 9 and they were 11 when they were getting diagnosed. And I'm glad that we can say now we have treatments, and we don't have to think about that at this point. We're just kind of, we have so many options. Now it's confusing because we have so many options, which is wonderful. So I'm really glad that passed, that door is closed on no treatment options, especially for NMOSD.
I would say there's a relatively new concept in the field of NMO called tolerization. Which means basically trying to re-educate the body that these targets, whether it's the aquaporin-4 water channel or maybe in the future MOG protein, that this is not foreign. You shouldn't attack this target. And if we're able to tolerize the body against these targets, then we'll achieve what was just mentioned, no need for long-term immunosuppression. And I think this is the closest thing to a cure. And tolerization is actually in human trials now. So I'm very, very excited about that. Looking forward to see what these results will serve the community.
I think I'll go maybe based on my last question, repair. We have spent so much time on trying to prevent, trying to help relapses. But again, with that just discussion I had, patients don't care about a relapse or pseudo-relapse, right? They care about their symptoms, and we have not offered anything meaningful in terms of wiping away those spots, repairing the brain, the spinal cord, and the eye. And I think over the next couple of years, we're going to see things. Maybe MS will kind of be the first foray into there, but neuroprotective and repair mechanisms, it's coming. And I think it's going to offer just a totally different line of hope for patients, and really exciting.
Fantastic. What a great note to end this panel on. Please join me in giving a round of applause to our fabulous panelists. Thank you all so much.